ago, I organized this panel at the annual conference of the International Society for Traumatic Stress Studies, and I invited the pioneers to sit together and talk about what they have in common, which was quite a daring and challenging endeavor, because those people really prefer to talk about the differences. But they collaborated. It was a really interesting panel. And at the end of the panel, I was invited to write a publication about this. So I approached all our pioneers and asked them to identify the 3 most important core elements from their viewpoint, the 3 most important elements that constitute a good PTSD treatment. And this is what they told me. So you have the 7 pioneers here, and they each identified 3 elements. And it was really interesting to see that emotion regulation, exposure, and cognitive works seem to be the elements that were most frequently mentioned. We published this together in the European Journal of Psychotraumatology a couple of years ago. And by the way, I'll be happy to also share the slides after the talk so that you can download them from your website. Now, let's talk about medication. Medication is easily and quickly talked because from my viewpoint, let me put this diplomatically, there is room for improvement in psychopharmacology for PTSD. There is consensus that the SSRIs and SNRIs are the first choice for PTSD, and we know that they not only improve the depressive symptoms that are frequently co-occurring in terms of comorbidity with PTSD, but they also address this PTSD symptom clusters such as re-experiencing and avoidance, and also hyperarousal. In America, the Food and Drug Administration approved paroxetine and sertraline only. I would assume that all the other SSRIs, the more modern SSRIs, will work similarly. And of course, venlafaxine is also effective. We need to be careful with regard to hypertension, of course. The more classic, the older tricyclic antidepressants, they also work quite well. As we all know, they usually have more side effects. This is one of the reasons why most of us will prescribe SSRIs first, but they do work. And especially in patients who have marked sleeping problems, which is very frequently seen in PTSD patients, an alternative to SSRIs may be something like amitriptyline or mianserin, because so we can use the sedative side effects of those drugs in order to treat their sleeping problems. This is one of the first studies that helped the producers of paroxetine to get FDA approval. As you can see, it's only a 12 weeks follow-up, of course, but there's a difference starting at 4 weeks measurement, and it continues and improves as compared to placebo. The 2 dosages, 20 or 40 milligrams of paroxetine, were quite effective. However, I have to say, if you look at the remission analysis, you see that paroxetine produces 29% of remissions, while placebo produces 17%. This is a statistically significant difference, but I'm not much impressed about this difference, frankly speaking. So I do think it would be wonderful to have more effective drugs in the treatment of PTSD. The benzodiazepines, they are the most frequently prescribed medications for PTSD, especially in family doctors' practice. Of course, they are effective in reducing arousal symptoms and treating sleeping problems, no doubt about that. But we need to be careful because they also come along with some cognitive impairment, and when doing quite challenging types of of exposure treatments in the treatment of trauma-related disorders, we really need the full cognitive function of a patient. So that might be something that you need to take into account when prescribing benzodiazepines. The dependency is usually not so much of a problem. However, what we know is that PTSD patients have a greater proneness to develop substance abuse as compared to other mental patients. So we need to be a little bit careful here. I have become less careful, frankly speaking, in my private practice since my retirement, but still we need to be careful. Neuroleptics, there is no evidence whatsoever for any efficacy in PTSD cases where there is no psychotic comorbidity. Of course, in patients who have comorbid psychotic symptoms, we would prescribe neuroleptics. But if they don't have psychotic symptoms, even especially in psychiatric hospitals, it is very frequently prescribed, but there is not one single randomized controlled trial out there that demonstrates the efficacy of neuroleptics in the treatment of PTSD in a stricter sense. Okay, so that brings me to the last part of my presentation, and I would like to talk about 6 things that I think we will talk about more in the future. One is the use of psychedelics in the treatment of PTSD. Then mini interventions will be an issue. 3-MDR, I will explain what this is. Acupuncture, interesting developments, really. Then the whole field of body-oriented psychotherapy, and I'll give you an example of somatic experiencing, which is really also promising. And then I would like to end by talking about efforts to improve resilience in traumatized individuals. So psychedelics, most of you will have seen this. This is the first study in severe PTSD that was published in Nature Medicine in 2021. And then the same research group published also in Nature Medicine 2 years later in the treatment of moderate to severe PTSD. So they developed a protocol where they use MDMA as an assistant to psychotherapy, and they were quite successful. There is still a lot of controversy about this. In Switzerland, there's a group of people who are trained and are increasingly using MDMA and also other psychedelics such as psilocybin and LSD and ayahuasca, for instance. But this is still in a, I would say, experimental state. And if you want to prescribe MDMA or other psychedelics in Switzerland, I don't know about Italy, by the way, then you need to have a special license to do so. But it seems to be, really everybody is talking about it. And for instance, Rachel Yehuda, who is one of the well-known proponents in the field of psychotraumatology, she published a paper in the JAMA very recently saying that psychedelic therapies address the cause of symptoms rather than merely suppressing them. Frankly speaking, I'm not 100% convinced that this is really the case, but I mean, we will respect what Rachel Yehuda is saying here. Then I would like to talk about mini interventions, and I give you one example that was published about 10 years ago in Psychotherapy and Psychosomatics by Regina Steil from Frankfurt in Germany. It is a very short intervention, only 2 sessions, one of 90 minutes, one of 50 minutes. She calls it cognitive restructuring and imagery modification. And it's basically addressing one single problem that is being that many survivors of child sexual abuse are complaining about, namely the feeling of being contaminated. So they say that even years and maybe even decades after the sexual abuse, they feel that their body is contaminated, that they feel the perpetrator's skin cells on their skin or their body fluids. So they do this very short cognitive restructuring about that feeling of being contaminated. And the results are really interesting and quite impressive. If you look at this graph, this is about the feeling. FBC means feeling of being contaminated. And in the intervention group, you can see pre, post, and follow-up, you have quite an impressive effect size. So it seems to be effective as compared to the control group where nothing much is happening. This in itself, I have to say, is impressive enough, but what impresses me even more is that also the PTSD symptoms go down significantly with an effect size of 0.90 pre-post. So this is the clinician-administered PTSD scale, the CAPS, this sort of the gold standard of measurement for PTSD symptoms. And you can see there is a significant difference between the intervention group and the control group. And I repeat, this is after 2 sessions with a distance of 1 week. So this is something I think we will see increasingly. There are other so-called mini interventions that are being applied transdiagnostically, not only in PTSD sufferers, but for instance also in people with borderline personality disorder or similar things, or also in patients with who went through torture experiences. A number of such very short interventions that address one specific problem rather than a diagnosis. That is something I would expect that will be developed more in the future. Now, this is 3-MDR. 3-MDR means multimodal motion-assisted memory desensitization and reconsolidation therapy. And this is really an interesting development. It is a combination of exposure on the one hand and movement. So it's sort of a body-oriented treatment approach. So people, as you can see on this picture, they walk on a treadmill. This is a patient, and the therapist is at his side, and he sort of walks into this virtual reality environment, which is individually tailored according to the person's individual traumatic experiences, and they're also playing music that remind them of the past trauma. So they sort of actively, physically approach the trauma via this treadmill and the virtual reality. And we have quite a number of good studies out there already now since 2020 that demonstrate their efficacy. Of course, it will be difficult to establish such environments in a psychotherapist's private practice, but in specialized institutions, outpatient services, it might be something that we will see more in the future. Now, I would like to talk about what Jonathan Bisson in this publication called the non-pharmacological and non-psychological approaches to the treatment of PTSD. And he identified a number of emerging treatments that are not really sufficiently evidence-based so far, but there are some good studies out there. Acupuncture, neurofeedback, Saikokeishi Kankyoto, probably everybody of you knows. It's a herbal preparation in Japan. And there's interesting studies out there about this. Maybe this is culturally bound. Maybe it only works in Japan. We don't know yet. Then somatic experiencing, then TMS and yoga. And I will give you 2 examples. One about acupuncture that's very recent in 2024, this year in JAMA Psychiatry, published quite a good study that showed that randomized people into acupuncture treatment and sham acupuncture. And they found quite significant differences in the CAT score again. So significantly better outcome in the acupuncture group as compared to the sham group. There's also some effect in the sham group, but the differences are significant. And what I found really interesting here is also that it's not only about the symptoms, it's also about the fear potentiated startle reactions. So the psychophysiological reactions really get better in the acupuncture group as compared to the sham group. I said I would talk about somatic experiencing. This is about a pilot study that has been done by Monique Pfalz in Sweden, and she's currently doing a larger study based on this pilot study. She doesn't have any results yet, but I just show you, this is from the pilot study where they only did one session of somatic experiencing, and they were able to demonstrate that people feel much more psychologically safe after the intervention as compared to the control. They also feel more socially connected after one session of somatic experiencing. And finally, also, she was able to demonstrate that the improvement in disrupted body boundaries in those patients is much better the more severe the child maltreatment was. This is a study in adults who had gone through child maltreatment, and the more maltreatment they had experienced during childhood, the better the improvement of disrupted body boundaries was. So this is also, I think, quite promising. Now, this is a picture also more than 10 years old. It's from the terrible earthquake and tsunami that happened in northern Japan. And many of you will remember, of course, I think something like 23,000 casualties. It looked really terrible. I went there, I think, 3 times, and it really looks such that people were really devastated as this person was. But in the same day, you also saw pictures like that. So the question really is, what makes this difference? What is the reason that some people are really, devastated and lose all hope, and other people somehow seem to maybe not strive, but seem to somehow keep their strength and keep their sense of humor and be able to function even after such terrible events. So we are talking about the term of resilience. Many of you know that it's difficult to define, but still we know something, and resilient people have been described as having self-esteem, self-confidence, curiosity, control of the environment. They can be seen, resilience can be seen as a personality trait that is modifiable, of course, but it moderates the negative effects of stress and promotes adaptation. Resilient people have obviously good interpersonal, supportive, satisfactory, positive interpersonal relationships, and also good problem-solving skills. Sorry about that. And they tend to show adaptive behavior in the areas of social functioning, morale, and physical health. Now, graphically, I think this is maybe helpful. What we can see if we see that red arrow as a traumatic impact here, we have people who just don't react. Those are the resistant people. This would be resilience. They would show a psychosocial, emotional, and psychophysiological response, but they would go back to normal quite quickly. Post-traumatic growth would mean that they would grow after, so they would reach a better psychosocial functioning level after the trauma, And vulnerability in terms of chronic PTSD, for instance, would mean that they would not go back to normal after the traumatic experience. So why is resilience so difficult to define? There are so many concepts playing into the concept of resilience. And just to mention a few of them, optimism, humor, gratitude, social support, cognitive flexibility. We've already mentioned post-traumatic growth, or you can also look at more neurobiological elements such as neuroendocrine factors or the reward circuitry that functions well or less well. So there are so many elements playing into this concept of resilience that it is difficult to really come up with a joint and with a consensus with regard to the definition of resilience. However, there are already some interventions out there that demonstrate that resilience can be trained, and I will just mention a few of them. Much is being talked about meditation, mindfulness, and acceptance-based treatments based on MBCT, which has demonstrated that it is quite evident and effective in the treatment of resistant depression and also in the treatment of residual depressive symptoms. Then also, of course, well-being therapy that has been developed by Giovanni Fava, based on Carol Riff's cognitive model of psychological well-being. And it is really an interesting approach because it does not talk about problems. It does not talk about trauma or any problematic symptoms or things like that. It's just focusing on improving the patient's environmental mastery, the patient's personal growth, purpose in life, autonomy, self-acceptance, and positive relations with others. So this is something that is really, I think there's great hope that applying well-being therapy in traumatized individuals may help them, maybe not so much to reduce their symptoms, but to enhance their personal resilience. Finally, also